one of the talks in our series related to anti-racist approaches to research. I'm really delighted to welcome Aisha Lofters as a speaker. Dr. Lofters is a scientist at the Women's College Research Institute. She holds a research chair in implementation science at the Peter Gilgan Centre for Women's Cancers. She's an associate professor in family and community medicine at the U of T. And of course, she's also a senior scientist at ICES and a member of our race and ethnicity data working group. So really delighted to welcome her to our speaker series. Just housekeeping, I'd like to ask, maybe we'll do questions at the end. If you have questions, you could put them in the chat. And then if there are not too many of them, I think I'll just call on people to ask them. If there are loads, I'll try to, consolidate if there are themes in them, and just to be a little bit more time efficient. So with no further ado, and just, sorry, the usual virtual meeting things, just if everybody could turn off their mics while Dr. Lofters is speaking. Great. So Aisha, with that, I will pass on to you.
Great. Thank you so much, and thanks for having me. As Astrid said, we should have lots and lots of time for questions and discussion. It's probably easiest if we save it till the end, because I can't really see everybody, and I'd rather at the end just kind of close the slide so everybody can see each other's faces and we can have a discussion. So here we go. What am I going to be talking about today? I wanted to share some experiences of working with community partners on research, and also describe some insights and lessons learned from this community partnered research. I'm going to walk through one example in detail, and then at the end just briefly touch upon two others that are actively going on right now, two other studies that are actually actively happening. So first, though, I did want to introduce myself. So, Astrid gave the bio that my usual blurb, but I also wanted to go a little bit further into it. So who am I? I'm a family physician. Despite that, I spend most of my time doing research. So I'm a clinician scientist. I do 70-30 when it comes to research versus clinical and policy work. I really focus on cancer screening and prevention. But I always say that very much I do that work with a health equity lens. So a lot of my work has focused on immigrant communities, racialized communities, and people living with low income, and looking at disparities in screening and prevention, and trying to think of ways that we can address those disparities. I did my PhD in clinical epidemiology with Rick Glazier as my supervisor. And as Astrid mentioned, I'm now an ICS scientist, and I've been so for many years. As you will see, I've not listed on this slide that I'm a community-based participatory researcher. I'm not an expert in participatory action research. I'm not an expert in community engagement. And that's generally not the type of research that I do. But what I am, I'm an ICS scientist with an interest in ensuring that the work that I do isn't just navel gazing, isn't just to add a line to my CV, and that it does have some type of impact for communities that experience marginalization. So through that lens, I have and do work with community partners and wanted to share my experiences. So as I said, I'll spend most of the time walking through one case study. The example that I wanted to talk about was one that's quite old now, as you can see from the dates on the slide. Was started many years ago, and it was called the Peel Cancer Screening Study. I always wish we could have come up with a more exciting name. That's the name that we came up with at the time.
Aisha, sorry, can I just say one thing? I apologize. Maybe I'm the only one. I'm only seeing your slides very small, which I think is because your camera is on. Laura, okay. Do you have the same thing, or?
It's pretty full screen for me. I'm not sure about others.
Okay, if I'm the only one, then just ignore it. I don't know why that would be. If everybody else is seeing full screen slides, then that's perfect.
How is that now after I turned off my camera?
I'm even at G-Wing, which is like on the, but anyway, all right, good.
Is perfect. It okay now?
It's good for everybody else, so don't worry about me.
Okay. I will stop spotlighting and I'll see if that fixes the issue. How is that?
Is that okay?
I think it looks good.
Okay. Yeah, it looks good now. It's good for me. Thank you.
Okay, perfect. No problem, no problem. So as I said, this is a study that occurred many years ago. You can see the dates that are on the slide. So over the next bit, I'll walk through how the study came to be, what was produced, and where it ended. So for my PhD work with Rick Glazier, who many of you know, I had focused specifically on cervical cancer screening for immigrant women. So using the IRCC database and looking at region of origin. So through that work, I had shown that women who had immigrated from South Asian countries, so like India, Pakistan, Bangladesh, Sri Lanka, were at the highest risk of being underscreened. This forest plot is one of the ones that was produced from that research. So if we look at region of origin, first of all, we can see that all the immigrant groups are to the left, so having lower rates of screening. And the group that stands out the most for being the furthest to the left was women who would come from South Asian countries. So studies from others and ones that I did as well after my PhD show that this was also true for breast and colorectal screening. So this slide here is showing cervical screening, but we also saw the same thing for breast, cervical, and colorectal, where consistently immigrants in Ontario who came from South Asian countries had lower rates of cancer screening. So after I did my PhD, I did my postdoc at the Centre for Urban Health Solutions at St. Mike's, which is now known as the MAP Centre for Urban Health Solutions. And I worked there with Pat Ocampo, who many of you may know as well. And Pat really emphasized for us in that postdoc program that when we're working in health inequities, we can't just park ourselves down in that problem space, which is the realm of describing the problem. She really emphasized for us the importance of moving from the problem space to the solution space. So ICES data allows us to do a really great job of describing the problem, but we do ultimately have to move beyond that. So along with another postdoc working with me at the time, Rebecca Lobb, we decided that this issue of cancer screening was a really great one to try to tackle the solution space. So a first question for us was where, and I mean literally where, to focus. So we chose to focus in Peel region. So for those of you who know Peel region, the reason would be obvious, but about 30% of the population in Peel is of South Asian ancestry, highest in the country. Many people in Peel are immigrants. About half the population of Peel was born outside of Canada, with India and Pakistan being the number one and the number two source countries. So we knew that this was really geographically a logical place to focus. We also knew that there was a really strong public health department in Peel and that there were many community organizations who were serving the South Asian population. So Peel seemed like the very logical choice. Another very important question for us was, do the stakeholders in Peel and does the community see cancer screening as a priority? If they didn't, that would certainly have affected our next steps. But initial meetings with Peel Public Health and a group called Punjabi Community Health Services confirmed that they were actually already interested in and working on this issue. So now we had public health and we had this community service organization who were both eager to address this issue. And then we next asked CCO, or Cancer Care Ontario, now part of Ontario Health, to be a partner, recognizing that this topic was very much in their wheelhouse, and strategically having a provincial agency on board would be a great help to move our work forward. So these initial three partners, so Punjabi Community Health Services, Peel Public Health, and Cancer Care Ontario, then connected us to other potential partner organizations in Peel, ultimately with a goal of forming a community advisory group. It's important to say that CCO ultimately was not part of that community advisory group, but they played an important role as far as making connections and networking for us. So we did then at the time create a community advisory group, and we had representatives from the local hospitals, the regional cancer program, community health centers, and then other community service agencies that had a South Asian focus. So we took time to meet in Peel region, which is very far from downtown where I'm based, but we would meet in Peel region because we wanted people to know that we were serious, we were authentic, and we wanted to meet where the work was going to be happening. And we also took time to work together with the group to create terms of reference, to be very clear about what we were doing, why we were coming together, how often we would meet, et cetera, and to get that down on paper so that everybody had that clearly documented. So to get things going, we, as in the researchers, decided to start off by conducting a literature review. We wanted to identify evidence-based interventions that had been shown previously to increase cancer screening. We wanted to get ideas from others who had come before us as to where we could start in our local context. And I'll briefly review what we found in that literature review afterward. We also proposed 2 ideas to the CAG, the Community Advisory Group, that they were excited about. One was to do a concept mapping study to understand barriers to screening in Peel and which barriers would be both important to address and feasible to address. And then we proposed a knowledge exchange meeting to share the results of both literature review and the concept mapping study. And I'll discuss more about the concept mapping and knowledge exchange event as well shortly. So I'm going to try not to focus too much on the research itself, as that's not really what the talk is about. But obviously, I have to talk a little bit about it to explain, the whole process that we went through. And what's on this slide here will also become relevant later on. So this slide just highlights the interventions that we found in the literature that do have strong evidence for increasing cancer screening. So those are client reminders and recall. So what that means is essentially, for example, some of you may receive letters from Cancer Care Ontario saying it's time for your mammogram, it's time for your PAP. So just reminding clients and patients about when it's time to be screened. Small media, so this means things like pamphlets, brochures, one-pagers, websites. Group education and one-on-one education are, pretty self-evident. This means educating people either one-on-one with somebody or in a group setting to talk about what screening means, how does the procedure work, what's involved, why do we do it, etc. Reducing structural barriers. So that's it's a huge one to unpack. But this could mean things like offering screening after hours, offering childcare, providing transportation, at-home testing, so things like the FIT test, or HPV self-sampling. So those are all examples of things that could reduce structural barriers. Reducing out-of-pocket costs, so probably more relevant in the US setting or settings where healthcare is not universal, but still relevant here because, again, there are indirect costs, things like transportation, taking time off work, etc. And then 2, directed towards providers, so audit and feedback, so letting providers know how they are doing as far as their cancer screening rates and how they're doing compared to their peers. And then again, reminders. So, in my electronic medical record, we do get reminders about patients who are overdue for screening. So these were all interventions that we found in the literature, so we didn't have to start from scratch as far as ideas as to how to intervene. So I mentioned that one of the outputs that we decided to produce was to conduct a concept mapping study. Again, I won't go into detail on this. There could be whole sessions about concept mapping, but briefly, concept mapping is a method that's both qualitative and quantitative, and it's also very participatory. So we asked community members, so residents living in Peel, primary care providers, health service organization representatives, and community service organization representatives to brainstorm barriers to screening for South Asian residents of Peel. So just list everything that they could think of that could be barriers to screening. Then once we had a cleaned up list of unique barriers, and there were hundreds, we next asked them to group those barriers into clusters that made sense to them. And then finally, we asked them to rate those clusters on 2 factors: importance to address and feasibility to address. So the pictures here on the right depict the maps of the clusters that were created and the 7 concepts. So those 7 maps correspond to 7 concepts, and those are on the left. So those were limited knowledge among residents about screening, health education programs, so essentially poor quality of health education programs, ethnocultural discordance with the healthcare system, limited knowledge among providers about screening and who should be screened and who shouldn't, the health system itself, patients' beliefs, fears, lack of social support, and cost. So these were the 7 clusters that came out of that concept mapping, the 7 concepts. So as I mentioned, we had asked people to rate these clusters on importance to address, and rate them on feasibility to address. So there were 3 barriers that were rated as both most important to address and most feasible to address, and those are bolded. So limited knowledge among residents, health education programs, and ethnocultural discordance with the healthcare system. So now we've kind of had clear direction as far as which barriers it was that we should be trying to tackle. Once we had the results of the concept mapping and the literature review telling us what were, some evidence-supported interventions, we held a knowledge exchange meeting, both with our community advisory group members, but with others from a broader selection of folks in Peel region, where we shared our findings and we had some small group breakout discussions. And the key messages that came out of that meeting were, number 1, community service agencies have untapped expertise, and they can be valuable allies in developing and spreading health messages. When I was putting this presentation together, it struck me that first key message, sadly, had to be realized slowly again in the context of COVID-19. During COVID-19, you had many community service agencies who said, hey, we can tackle this, we can help to support education and vaccination. And it took quite a while for the powers that be to really let the community service agencies do what they do. But they do have untapped expertise. They know the communities well, various communities well. They're at the front line, and they really are experts and often are not considered so, sadly. The second key message that came out of that meeting was that formal partnerships between organizations of diverse size and expertise, but with common goals, can have a synergistic effect on efforts. So if you remember, I talked about regional cancer programs, community health centers, community service organizations. So these are all very different types of organizations, all with different areas of focus, different mandates, but all of them did have this common goal of increasing cancer screening. So coming together, the group really felt like they could really build on each other's strengths, and that strategically, it really was a synergistic effect with the work that they were each trying to do. But the third key message that came out as a note of caution was that the success and sustainability of the community advisory group, as well as whatever interventions that the group would select, would really depend on community engagement and depend on how group dynamics and power dynamics were addressed. So bearing in mind what we talked about at the very beginning, that people really have to feel that this is an important issue. And if they don't, we have to think about why not and how to address that. So that's the community engagement piece. And then also just recognizing that when you do have these different organizations of different sizes, different expertise, different mandates, how do you address those dynamics and hierarchies that undoubtedly and inadvertently do exist? So that was a note of caution for us from the community advisory group to bear in mind. So after the knowledge exchange meeting, we continued to work with the community advisory group to think, okay, what do we want to do next? And some of the things that they wanted to work with us to answer were, first of all, where exactly in Peel do we want to start? What networks already exist that we can take advantage of? And what do we want our health messages to say? So we decided to tackle these questions in an academic manner, being academics. So to work to produce geographic maps, to think about where in Peel to start, to conduct a network analysis to understand what networks to take advantage of, and then to think about those adapted health messages. So first up, we produced maps. And when I say we, I really mean Peter Gilgan, who many of you know. So he produced maps of Peel using a technique called LISA, which is Local Indicators of Spatial Association. So there's one here on the left as an example of a map. So highlighting areas in Peel where there were significantly lower rates of cancer screening and a significantly larger South Asian population. So on the right is a publication that we got out of this work, which again, Peter was really instrumental in. So if you look at the map on the left, the salmon colored areas were our target areas because that's where we saw the lower rates of screening and the higher proportion of South Asians among the population. So the blue areas were the areas that were the opposite. So they had higher rates of screening and lower proportion of people who were South Asian. So we knew salmon, that's where we should focus. And blue, that's really not where we should focus, to be blunt. This map here was for breast screening, but the 3 maps for each screening type looked quite similar. We also conducted a network analysis, working with an expert in this area named Bobby Carruthers, and we sent out surveys in this work to stakeholders at various organizations in Peel and produced multiple network maps like the one on the right. So our key findings from this work were that there really were opportunities to increase communication, increase collaboration, and increase referrals in Peel's cancer screening network. Peel's community health centers specifically were at the periphery of the communication and collaboration network. So despite the mandates of community health centers and really their important role in screening, they were not really well connected when it came to communication and collaboration in the cancer screening networks that did exist. Screening facilities, so by this is typically like Ontario breast screening program sites, had the fewest communication links. So from a very practical point of view, despite being the place where screening occurs, there's not a lot of communication happening between them and other organizations. The 2 hospitals, not surprisingly, were critical within all networks. So they were often in the center of the various, in the center of the communication, collaboration, and referral networks. And then we saw that community service organizations were on the periphery of the referral network. So again, there were lots of opportunities to improve communication, collaboration, and referrals between these different organization types in Peel region. And this was the paper that came out of that work about using organizational network analysis to plan cancer screening programs. So the Canadian Cancer Society had also been represented on our community advisory group, and a program that eventually came out of CCS was the Screening Saves Lives program, which involved peer education by peer health ambassadors who would educate others in their community about screening. And in Peel, this program ended up focusing on the South Asian community. So this was really exciting for us because it was using evidence-based strategies. So remember on that previous slide, we had talked about small media, so they were using things like pamphlets, brochures, one-pagers. They were doing one-to-one education, so they would have informal and formal conversations with people. They would do group education sessions, which again is supported by evidence as being all ways to improve cancer screening. They also worked with us and created culturally tailored messages and worked with the community advisory group to make sure that the messages about cancer screening were relevant and really spoke to the various South Asian communities. And then they worked with community organizations. So again, our community advisor group actually transferred over to the Screening Saves Lives program and was really able to inform the work that they were doing, which was really thinking back to the key messages from the knowledge exchange meeting about the strength of community service organizations was a real boon for us. And then when you think back to the concept mapping, it addressed the key barriers of limited knowledge among residents because it was an education program, health education program because it was one, and then ethnocultural discordance with the healthcare system because all of the peer ambassadors were themselves from the South Asian community. So it really was about peers, speaking to peers about the importance of cancer screening. We ended up writing this publication about the experience of working with our community partners and true knowledge exchange. And as you can see highlighted in the results, we really highlighted the program for coming out of CCS, this targeted community-led program, and we're very, very excited about it. And then the program lost its funding. So CCS ultimately was not able to sustain a Screening Saves Lives program, and I don't fault them for it. As a charity, it's often very hard to keep this type of work going, but definitely was a disappointment for us to see that after all this exciting work had happened and we'd kind of passed the baton over to Screening Saves Lives, that the program was ultimately not able to be sustained. So at this point, I'll stop and walk through each of these lessons that I certainly learned in the process of working on the Peel Cancer Screening Study. So the first one is that each community consists of many communities. So I spoke about the South Asian community as if it's one monolith, but really there's people coming from many different countries, people of different religions, speaking different languages, different social class. People who were new arrivals, people who had, families had been here for a couple of generations. And I think when we do this community-based research, we often speak in these very simplistic terms. We'll talk about the Black community, the LGBTQ community, as if there is kind of one overarching mindset or one point of view. And I think one important thing to just recognize is that you're still speaking about many different individuals who are going to have different viewpoints, feel different ways, have different priorities, have conflicts. So just to recognize that each community does consist of many different communities within it. The other point which I wanted to make, moving to the right, which I heard a few times now and can't say enough, really, is the importance of community service organizations. So for us as academics, as researchers, as methodologists, that's our expertise. But then there are others out there who are experts in what is happening every day in the day-to-day lives of community members, specifically people who experience marginalization. And we have to recognize the expertise that they bring and the importance that they have as far as, daily affecting people's lives and recognizing what's happening in the real world. Another lesson that we learned was involvement and engagement from the organization, not just the individual. So throughout this process of the Peel Cancer Screening Study, there were several times where an individual who was working with us on the CAG, who represented an organization, would leave, moving on to a new job, new role, parental leave, etc. And sometimes they would pass the work on to somebody else who was just as engaged, just as interested. But sometimes we really would lose an organization because it had been the individual who'd been engaged, but there hadn't really been that buy-in from the organization. So depending on the nature of the work and why someone's at the table, it's really making sure that the organization itself is engaged with the process, not just that particular individual. The other thing is to listen. So listen both to what people are saying and not saying. I think one thing that often happens in research is that we tend to do community engagement in a very tokenistic manner. So often we've decided what our research question is going to be, what our outputs are going to be, what we want to do, and we're just looking for somebody to say, yes, sounds good. And if we're going to do this in a meaningful way, we have to be willing to hear when people say, nope, I don't like that idea. I don't want to pursue that. And to be willing to take that into consideration and to respond to it. And if we're not able to respond to it, to be very clear as to why. Also listen to what's not being said. I remember at some of the meetings with the CAC where people weren't saying it, but you could tell that there was some frustration, that things were moving slowly, or that there wasn't more action. So it's a matter of being able to both listen to what's being said and to read the room. Giving community partners a skeleton to work from. So again, through the process, we proposed things like the literature review, we proposed the concept mapping. I don't think it's necessarily fair to go to community and just say, okay, tell us what to do. Sometimes, that can be appropriate if people have ideas that they've been holding for a while. But often if we go with no real we have to go with a bit of a straw dog and say, here's what evidence shows us, here's what is possible within the funding, the models that we have, give people a skeleton to work from, and then that allows them to provide feedback on that skeleton. Be aware of researcher ego. So I'm sure many of us love to think that we are very humble, but often we can go into these spaces, again, as I said, considering ourselves as the experts, the one who knows what's happening, but we have to recognize that we're experts in some areas, but not in others, and go into the space with humility. So to be able to say that, you don't know what you don't know, to recognize that you don't understand people's lived experiences, to be able to give others the floor and let them speak really, really is important, I think, for this type of work, being humble and being authentic. Related to that, community partnered work requires time. It takes a lot of time to develop these relationships. I talked to earlier about, even the time to travel to Peel was a lot of time, but time to get to know people, to understand where people are coming from, why they're at the table. It's not something that you can do quickly and easily if you want to do it in a meaningful manner. So that really means budgeting that time in research projects and in grant timelines, et cetera. And then there are the practicalities of the CV. So I showed through the presentation several papers, and I wasn't doing that to show off, but just to say that, especially at that time in my career when I was a postdoc and very early, that because this work takes time, we wanted to recognize that we still needed to be producing. So the way that we did that was to write papers about the process. So writing papers about the concept mapping, about the knowledge exchange, the network analysis, so that while the work was happening in a way that mattered to our community partners, we were still, from a practical point of view, producing to meet the requirements for our academic homes. And then the final lesson learned, which I don't have the answer to, is just what happens when the funding is gone. So as I said, we were so happy when we passed off the baton to the Screening Saves Lives program and thought, this work will continue. And it did for a bit, and then the funding ended. And this is a very common issue that we face in the land of research, where we get funds, we do research, we have successful interventions, and then the funding ends, and then what happens? And this is really an ethical issue too, when we think about partnering with community, getting people who invest their time, who volunteer, and then at the end of it, nothing. So I don't have an answer for that one, but definitely something that's really important for us to think about in the world of community partnered research. Another big lesson for me was around the use of a guiding framework. So I didn't mention it earlier, but we did really use this knowledge, the CIHR knowledge to action framework, to guide this work. So we started off at the bottom talking about identifying the problem, adapting knowledge to local context, looking at barriers to the concept mapping, selecting the interventions that we wanted to use. We really did use this knowledge to action framework. And this is certainly not me saying that this is the one to use. There are tons and tons of theoretical frameworks out there. I will say, coming from a very pragmatic and quantitative background, this is not something that comes naturally to me, but I've learned that having a theoretical framework really, really does matter, because we all come at this work with our implicit ideas and assumptions and hypotheses. So I think we need to be explicit about it and have our theoretical frameworks as far as the work that we're doing and why we're doing it. So the Peel Cancer Screening Study, as I said, is kind of the main example that I wanted to talk about. I'll talk just briefly about two others, and we'll have lots of time for questions. I wanted to talk about two others that are ongoing work, ongoing examples of community partnered work that does have ICES connections. So the first I'll talk about briefly is with the Walnut Foundation. The Walnut Foundation is a men's health support group. It's for Black men with prostate cancer. Many of the men who are part of the group are of Caribbean ancestry. I was introduced to this group by Dr. Jackie Bender, who also does a lot of community partnered work. And essentially with the Walnut Foundation, one of the challenges that they had come across was trying to convince people of the importance of looking at prostate cancer among Black men in Canada. And one of their challenges was that there were no statistics. There were no numbers to be able to say, X% of Black men versus other men. So nothing to really catch the eye or the ear of policymakers. And we do know that at the end of the day, a lot of times with policymakers, they want to hear those population-based numbers. They had come through Jackie to me to ask about where can we get these stats on prostate cancer for Black men in Canada. Now, the short answer for that is nowhere, because we don't have race-based data in Canada. So we did talk it through with Walnut, and we decided that what we would do instead of looking at race, which we couldn't do, was to look at immigration, because as I said, a lot of their members were immigrants from the Caribbean or were first generation Caribbean Canadians. So what we ended up doing is looking at prostate cancer incidence among immigrant men in Ontario, looking at region of origin. So this graph was produced from that work. And what you'll see is that men from the Caribbean and men from Western Africa really have a much higher age standardized incidence rate of prostate cancer in Ontario compared to other immigrant groups and compared to long-term residents of the province. We are now trying to get this paper published. Two members of the Walnut Foundation are co-authors on the paper. I've shared the findings with the group at large and presented to the Walnut Foundation, and we're now talking about qualitative research that we can work together on. As well, the Canadian Cancer Society, they're not co-authors on the paper, but we've let them know about this work from the beginning, and they're quite interested in seeing it as well. And they are, not because of this, but they are now trying to focus a bit more on the issue of prostate cancer among Black men and among immigrant men in Canada. Another group that I've worked with for several years now is the Olive Branch of Hope. The Olive Branch of Hope is a cancer support service group specifically for women of African ancestry who've experienced breast cancer. I've worked with them in numerous projects over the years, and we've developed a trusting relationship, but I can never assume that they're going to say a knee-jerk yes when I ask them about research. Every time I come to them with a research project, they always take their time to review, to make a decision. The ED will bring it back to the group at large because they've been burned by others who want a letter of support, who want to use their pictures, want to take a tick box approach, and then they never hear from them again. So one project that we're working on right now, it's involving ICES data that was recently funded through CIHR through one of their COVID-19 grants. And the nominated PI is Dr. Juliette Daniel from McMaster, is going to be using both ICES data and using qualitative research to understand what has been the effect of the COVID-19 pandemic on the experience of breast cancer survivors who are immigrants. So we're going to be using ICES data to look at quality of care. So we know that quality of care for everything was affected during COVID, including cancer care. So just to see were the gaps, are there gaps in quality of care for immigrant women versus others, and also looking at qualitative research to understand people's experiences. I did want to briefly touch a bit on reciprocity. So I've posted up here two flyers. So I spoke at a Walnut Foundation event earlier this year. I've spoken at a couple of Olive Branch of Hope events as well over the years. And this really is about reciprocity. So it can't just be that I'm going to these groups and, picking their brains, getting their ideas, getting letters of support for the grants without also contributing back to their group. So it's the least I could do. And I'm taking on a summer student this year, so hoping to have a summer student help to support Olive Branch and Cope with some project management. So just recognizing that with these relationships, it's not just about what they can do and provide for us, but also how we can help to support them with their daily activities. So just some more lessons learned, and then we'll have time for questions. So first, thinking back to the Walnut Foundation example, population level findings used in ICS data really are valued by many community partners. I've heard this many times over the years with Walnut, with Olive Branch, with the Peel Cancer Screening Study. It really, really is valuable to community service groups to be able to say, here is this percentage, here are the numbers for Ontario. It really does make a difference when they're trying to provide high quality evidence and they're trying to get policymakers' attention. Without the numbers and the data that we can produce at ICS, it's very, very hard for them to get policymakers' attention. So I think that's just one really, really important point to highlight and one of the real strengths of what we can do at ICS. Also, making sure to keep partners updated and share preliminary results. So with the Walnut Foundation, it has been a long road trying to get this paper published. Those of you know that paper can sit with the journal for several months and they reject it and it's on to the next. So I've really made an effort to try to keep them informed, let them know what's happening with the papers, presenting the data. We're presenting at some conferences coming up because research moves really, really slowly. We are all used to that, but for community partners, that can be challenging, surprising, and frustrating. So making sure that you're keeping partners updated and informed at all times. And then I talked about the strength of the work that we produce at ICS, but when you combine it with qualitative work, I think there's really real power there. Having the numbers to be able to say, here's what's happening for the entire population, but you can't ask the data why. And you can do that with qualitative research. You can talk to people, get details and hear stories. And the combination of qualitative work and quantitative data from ICS can be really, really powerful. And then finally, as I mentioned, relationships really do have to be reciprocal. So it's not just about what we can get out of community partners, but it's a partnership. There's reciprocity there, and thinking through how can we help them, not just in the context of the research that we're doing, but in their overall context of what they're trying to accomplish in their mandates as well. So I will end there and open it up for questions. And I'm going to end the slideshow so that we can all see each other and turn my camera back on.
Thank you so much, Aisha. That was an incredible talk. I really appreciated how much you oriented it to, partially the work that we do here, and also so much around just reflecting on lessons. As you know, for some of the work that we're doing around the race and ethnicity data framework, which I think we should be calling probably a health equity framework, that we do want to do what we can to support more partnered research, community partnered research, more community engagement. But, you also showed us the importance of implementation science, and I think your comments about qualitative work, all of that really important. I'm going to open it up to questions. If there's not, I don't see one in the chat yet, and people can put up their hands. The chat is now all about my technical difficulties. I'm wondering, Aisha, if you could reflect a little bit, because again, as an institution, what can we do to provide more support? Like you're embedded in other institutions too, and I don't know what kind of support you got for some of the early work that you presented when you were first trying to engage. But are there things that, like, as an institution, we can do to support that kind of work?
Yeah, so definitely when so I talked about at the beginning that we knew that Peel Public Health and that some of the community service organizations in Peel were strong partners. So we didn't just know that intrinsically. It was folks at St. Mike's who were deep into the world of knowledge exchange and partnerships, who worked with us and who made those initial connections for us, and we made connections through them. So I think it's sometimes having that expertise in the institution, and I don't think it's possible to have like one person who knows all about every potential community partnership, but even about the processes, if there are particular priority populations, having sometimes institutions will have like PFACs, so patient family advisory councils, or particular advisory groups for the institution overall who can help to provide that support. But it's not easy. It's not something you can just kind of dive into without some help and support and expertise in navigation. So I think from an institutional point of view, you know, having those resources in-house can be a huge help for this type of work.
Yeah. And that's what we're trying to build at Laura's group for sure. And even having materials like accessible materials about ICES, because I think, again, we also want to encourage more community organizations to use our ARC program and to know about us, you know, and ways that we can sort of serve them better. I saw Beju had a hand up, and I see Beth also has said she's got a question. I'm trying to think.
Hey,
Hi, Aisha. How are you?
good. How you doing?
Good. Nice to see you. Thanks for
too.
that. That was really, really great, and nice to get sort of reminded about all the wonderful work that you've done. So the question that I had for you sort of is something that I've been thinking about and struggling a little bit with, is the idea of community engagement when you're dealing with communities that aren't monolithic, as you referred to, and they're broad. And I'm just curious, from your experience, how did you deal with this? So, you know, the South Asian community is actually dozens of different communities. So how do you engage in a way that is representative and that people will buy into? Because again, as a member of that community, I would also say, like, if you went to the Hindu temple, I'm not sure I would see that as representing my interests, because I don't belong to that group, right? So how do you reconcile that? And does it mean that you actually do have to reach out to 17 different groups, or do you sort of, you know, do the best you can and just be transparent about it?
Yeah, I think there's no easy answer. And I think at the end of the day, it comes down to doing the best you can. So sometimes for us with the advisory group, it would be somebody saying kind of off the side, like, because again, like, I'm obviously not a part of the South Asian community. I'm a part of a community where I know that people often view it as one, but there's many different, and often there can be conflict, right, and turmoil and things like that. So it would be
South Asian community.
it would be people saying to us, hey, you know what, you don't have a lot of representation of X, or I'm not feeling comfortable speaking out because everybody's coming from here. So then we would try and make efforts to make the group more inclusive and just try to be very transparent about it. Because I think it's very easy to end up with one particular community and feel like you're representing the entire community, which you're not. So I think it's really just a matter of, I think one key is recognizing it, right? So knowing that, and knowing that means you can't have one or two people represent the entire community. So we had a large table. What often happens we do as researchers is that we bring one or two people to our table and that they're representing the community, as opposed to having us at a table that's maybe 10 to 12 people, which again still can be challenging. But I think that way at least you do have a broader representation, and there is more of an effort there. But I think it's about understanding what's the history, what do I need to bear in mind, and asking people those questions, and then trying as best as you can to just be honest about it, and then being as representative as you reasonably can. But it's definitely not a straightforward and easy thing to do.
Yeah, and I mean, I think, you know, we draw the analogy with the First Nations communities where we have like the Chiefs of Ontario as an umbrella organization, but they're also, you know, 70 different nations, and
Yes.
it's, you know, it's not monolithic, and it's important to sort of recognize that and don't assume that people will be speaking for others when they may not be.
I think that's what it really comes down to, is you can't just say, well, I asked this person and they said it was fine, so that means everybody thinks it's fine, right? I think that's, and we often do that. Like, it sounds ridiculous, but we do often do that in research, right?
No, absolutely.
Yeah.
Great, thanks.
Thank you.
Beth, do you want to ask your?
A bit of a cold, so
You're just muted.
I'm still muted.
Oh, now we can
No,
hear you. There's a
good
bit of a
now.
delay, but it's good now.
You can hear me?
Yes.
Hear me now? Okay. Thank you for that presentation. It's interesting because I actually also use concept mapping for my PhD and my postdoc. So it was nice, and I'm pretty sure I referenced some of your papers in my analysis. But my question was around, and I often talk about this when I'm talking about community-based research, is the ability to, when someone says, no, we don't want to do this, to be able to listen to that. And I've actually was wondering if you had any thoughts about how to address the situation. So if you're coming and you're like, we think that this, you know, based on data or based on what we've heard, that this is an area that we should be looking at, and then you have a community or whoever you're working with, your partner, say like, no, we don't want to do that. If you've ever encountered that, and how you sort of then what your next steps would be. Would you then say, okay, let's try something else, or would you just walk away from that and say, okay, you said no, that's it. I heard you. You just had any thoughts on that?
Yeah, it's a good question. So for us, when we approached our initial partners, they were already interested in cancer screening and engaged. I think if they had not been, so I mean, it made it easy in that from that perspective. I think if they had not been, a next step might have been to ask if they knew of any others who were interested in that area. I think it's hard. Because quite frankly, that was my interest, cancer screening. So if they had said, you know what, we really think diabetes is where we should focus, it wouldn't have been sincere of me to say, okay, because I didn't want to go down that path. So I think honesty is a big part of it. So to be able to say, like, I really want to focus on this area. If you don't, please be honest. And then, you know, we can agree that we're not going to work together on this particular project. Do you know others who would like to? I think that's I think honesty is one of the really big parts of working with partners, is to be able to say, okay, you want to do this type of research. I don't have expertise there, so I can't do that. Or this funding call wants to focus here, so we kind of have to do that. So just to be able to have those relationships where everyone's comfortable being honest with each other and saying, okay, maybe not this time, and maybe there's another time that we can work together down the road when there's something else that we align on.
That makes sense. Thank you.
The practicalities too of funding is that, like, this is one of the challenges too with applying for funding, is that often when we go to community partners, even when we are willing to be open and to co-develop an idea, reviewers still say, okay, great, you're going to co-develop it, but what's it going to be? Like, they want to already know what you're going to be producing, which I find is a big challenge with how we're currently structured with research.
Jeetha?
Thanks, Astrid. Thanks, Aisha. That was really wonderful. And it sounds like a really interesting project, and even the approach to community engagement. I just had a question. You know, when we work with Indigenous partners, like as Beju mentioned, the Chiefs of Ontario, the level of kind of oversight and control of the results that come out of the studies is quite significant. And I was wondering, with this project, was there kind of an approval mechanism when you were going to publish those papers, whether about the process or the findings? I'm just curious to hear.
We did. There wasn't a ton of oversight, but that was part of the terms of reference. That any papers that were going to be produced, the group had to know about it. They saw all the data beforehand. If they wanted to, they could be co-authors, you know, going with the usual criteria of what authorship means. And often they just weren't interested from that point of view. They more wanted to see the practical aspects. So like the network analysis, the concept maps, they were more focused on how they could use it in their work. But we did have, in our terms of reference, we did discuss the idea of academic outputs had to be approved by the group. The data had to be reviewed by the group, et cetera. So that definitely was a part of the work that we did. And even now with the work we're doing with the Walnut Foundation, two of the members were interested in being co-authors. So, you know, they were involved in the whole process. They got to see things like ICS DCPs and, you know, understanding somewhat, you know, the data and the graphs and things like that, because they wanted to learn from an academic point of view. They were just interested in that learning piece. So I think it's just letting the groups, again, within being realistic, just helping them decide how much they want to be involved.
Thanks so much.
No problem.
It brings up a good point, actually. I mean, just thinking about some of the resources, because it is, you know, always the case. I mean, if it's not with the chiefs, if you're working with individual First Nations communities, for instance, that you have these kinds of agreements. But I'm not sure that that's always done when people do engagement with community groups. And it sounds like it's a very, very helpful, right, to lay all of those terms out. So I wonder if we could even showcase one of them for people to see what goes into those kinds of agreements, you know, to start thinking about that as they do it.
Yeah, I think terms of reference, I mean, the process of creating terms of reference is not exactly exciting, but I think it's so important to be able to come back to something so that when there are issues, you know, to be able to say, okay, we all came to consensus on these points, as opposed to, you know, something blowing up at the end because there wasn't clear agreement at the beginning.
Yeah, no, absolutely.
I was just going to make a comment as well. Just actually when you're speaking a little bit about, letting people guide in terms of like how much information they wanted on like the academic side. That was going to be my question as well. Is, when you did those concept mapping exercises, was there like a desire from the community to go into more detail on like kind of those academic methods? I'm just wondering when you're doing this kind of work, how much should you get into the weeds? Versus like keeping it higher level, or maybe you mostly take that direction from the community?
I'd say mostly from the community. It might depend, right? Because there were, again, we had a pretty diverse advisory group. So there might be individuals who want to be more involved. I think it's just leaving the door open if individuals on the group want to be more involved and get more involved in the weeds, that they can start coming to separate meetings, but keeping it, I think, relatively high level and practical for the group overall. And again, just kind of coming back to, what is the point of all this? I think we can get excited about methodology and things like that, which for, again, particular people might be interesting, but in general, the group sees that as a means to an end. So just saying, here's the method we're doing, here's why, here's what it accomplishes. But, if people want to get more involved, giving them the opportunity kind of offline or in other spaces.
Isabella, do you want to ask your question?
Sure. Thank you, Aisha, for your presentation. As Lauren knows, the theories and frameworks within knowledge translation always excite me. And so I was wondering if you have any, I know we're considering some for the race and ethnicity data framework as well. Do you have any tips for us on how you went about choosing the knowledge to action cycle? Were there any others considered? Any pros and cons that you can remember from your process?
Yeah, so the knowledge action cycle really, to be honest, came from my partner, Dr. Lob, who just really thought that it was a good framework to use for what we were trying to do, which is really that kind of, we've identified a problem, now we want to move into action. I would say it comes down to reading, right? So if there are papers that you like and you liked how they structured it, like if you liked interventions, if there were implementation studies that seemed really promising, and going back to see what were the frameworks that they used, I think that's like how we do that with research, right? That often we will look at the examples of others and how they structured their research and structured their papers. I am not tied to any one particular framework, to be honest, because I find that some of them are quite similar at the end of the day. But I do think I've learned that it is important to have some type of framework that's guiding the work that you're doing. But yeah, I think it's really just a matter of reading, looking at examples of folks that have come before and seeing if what they have used resonates with what you're trying to do.
Thank you, Aisha. Thank you very much.
Ria?
Thanks so much for the presentation. It was excellent, just to showcase all the work that you've done. Amazing. I sort of have two questions. One is sort of next steps in terms of students and whether students are really getting the proper training for this type of research and this type of direction in terms of community-led and evidence to action. And the other one is there anything we can do in terms of our funders to convince them to provide more sustainable funding so that once we do demonstrate that this works, that we have additional funding to continue it?
Two good questions. With students, I will say, I think one of the reasons I was very lucky was doing my postdoc at Centre for Urban Health Solutions and with Pat, because I often in postdocs, there's a focus on like you produce, you have to get outputs, trying to get a scientist job. So for that postdoc fellowship really to be focused on interventions on that solution space, I think was actually pretty unique. And it was with the support of Pat to be able to say, okay, we'll just, publish on the process so that you're kind of meeting the check boxes for academia. But I think that can be really challenging for students who do tend to have short timelines because it takes time, right? So it's kind of, you've got a short timeline as a student, and these relationships take time. So I think that's definitely a challenge. From the funding perspective, CIHR has those meeting planning and dissemination grants. They tend to have these kind of smaller grants. And I really think that type of model could be adapted for community partnership work, because I think it takes, to have funding grants that are specific to building community partnerships and developing an idea with community partners wouldn't require a ton of funding. There need to be some funding to provide for transportation, for meeting costs, for technology costs, perhaps for partners, and to use funding like that to develop an idea that then could come to a traditional CIHR project grant, I think would be a very achievable way, but definitely would require the funders to also see the importance of it.
You.
Also, in terms of sustainability, Aisha, I was sort of thinking about, for your first example, I don't know whether you used ICS data again or CCO data again to see whether some of the interventions were working, but to the extent, and I appreciate this is the easy work around sustainability, that the constant, like a feedback of data, we've gotten much better around having dashboards, and you think about what we did for COVID, like we were doing those weekly at FSA levels for public health units, and and obviously that's not sustainable. We don't have real-time data for everything, but whether there's also a piece where you are leveraging what we can do, which is the sort of the feedback around the outcomes that community organizations are trying to intervene on. And whether we can think a little bit collectively about how we fund that piece at least.
Yeah, I think that's a great idea. And it's such a good point, because as I said, like the community organizations really do value the data, right? Because they're often not surprised by the data, but they need the data to be able to move things forward. So to be able, and it's the numbers are compelling, and I do speak to policymakers from a sustainability point of view. I think getting a program or getting things that actually have sustainable funding really can be strengthened by having that ICS data that we can provide.
Great. Laura, do you want to wrap us up?
I'm sorry, I was just on mute. Thank you so much, Dr. Lofters. That was fantastic and really helpful, especially as we start to think about community engagement going forward with our health equity framework. And I think this will really be useful to a lot of our scientists and staff as well, who are kind of doing this work going forward. So this was a great discussion, really appreciate it, and appreciate everyone for attending today and the great questions as well. So thank you so much.
Thank you so much, everybody.
Great, take care, everyone.